Either Michael.
Okay, so we are back live. This is Senate Health and Welfare, and we're moving on to markup S-190 and 197. So Jen, thanks for coming back.
You are welcome.
You're stretched thin. We appreciate your time. We got you.
This is cross it. All right.
Yeah. it is.
Jen Carving, Legislative Council. So we are looking at S-190, and I do have a comprehensive new amendment for you. So I've got all of the changes from, I think we've only done the bill as introduced. So all of the changes from the bill as introduced are bold and highlighted. Language to be struck is bold and struck. Not all of this is necessarily consensus language among everybody, but hopefully it gives us a place to have more conversation. So S-190 is an act relating to the Green Mountain Care Board, reference-based pricing, and hospital outsourcing of clinical care. The reference-based.
Do you want to put it up?
I thought I was. Yes, I do. Thank you. I had it scrolling on my screen.
We do have it.
No, thank you for pointing that out. I thought I was ready. All right. So we have reference-based pricing, no changes to begin with. But then when we start talking about hospitals and insurers expressing in their provider contracts rates in as reference-based pricing, I have added, so first it was for provider contracts entered into on or after October 1st, 2026. The board had recommended adding contracts entered into, amended, or renewed. Probably makes sense, but wanted to flag that for you here. On or after that date, each hospital and health insurer shall, instead of express, we would say begin expressing. I think this is part of our conversation before the town meeting break. Begin expressing as a percentage of Medicare or another benchmark, if deemed appropriate by the board, the rates for items and services identified pursuant to a collaborative process between the board and representatives of Vermont hospitals. This was the piece where there was concern about an expectation that everybody be ready to go and wanting a way to identify which items and services are ready to be expressed in that manner. So hopefully that looks familiar. I don't know if you want me to stop each time or just keep going and listen until you.
Let's go through the whole thing. That'll help the committee. And then we'll come back to decision points and we'll.
All right.
Have the
Good news
gallery
is that at least some of this 24 pages is struck language, so it's not all of it. This next provision moves out by a year from October 1st, 2026 to October 1st, 2027. The requirement for hospitals to get a unique NPI to use on all claims filed, and this was reflecting the January 2028 implementation at the federal level. And this was a date that I believe had been acceptable to the hospitals. I don't want to forget. Okay. Then so I'll just identify what's still in here, definitions. This is, I hadn't heard anything specific around the including Medicare rates in the public reporting of hospital items and services. So I didn't make any changes, but you may hear otherwise. Then in the language from the bill is introduced around the board establishing a default percentage, default cap of Medicare for new service lines or new services under the CPT codes and a default maximum percentage generally. Instead of that language, I have the board's proposal here saying until the applicability date specified in the Green Mountain Care Board rule, and we settled on applicability date because I was looking for a date, some sort of a date certain so people knew when this would be starting, but the effective date of the rule may not be the same as a date of application of when it should apply, so the board would need to include an applicability date in its rule that establishes the reference-based pricing methodology. So until the applicability date specified in the board's rule establishing the reference-based pricing methodology for all items provided and services delivered in Vermont hospitals. First, a hospital shall implement any commercial reimbursement rate reduction ordered by the board under the hospital budget review by first reducing its commercial reimbursement rates that exceed 500% of the Medicare adjusted base rate, which will be a term you'll see defined in a moment. Or if the hospital doesn't have any commercial reimbursement rates that exceed 500% of the Medicare adjusted base rate, by first reducing its commercial reimbursement rates that are the highest in relation to the Medicare adjusted base rate. And a hospital shall not increase any commercial reimbursement rate that, as of a date certain, in this case, put in July 1st, 2026, exceeded 250% of the Medicare adjusted base rate. I will pause here just to say, I've seen a different proposal from the Hospital Association, so this is not consensus language, this is the board's proposal. And they were great at working with me about helping me clarify some of the proposed language. As used in the subdivision, Medicare adjusted base rate means the standardized Medicare payment amount for a hospital inpatient, outpatient, or professional service as determined under the Medicare program. It's calculated prior to the application of any hospital-specific, patient-specific, or policy-based payment adjustments, and reflecting only the core payment methodology used by CMS to establish baseline payment levels, which include adjustments for geographic factors such as wages. It's the board's proposed definition. Section 2 would be a new section added into the subchapter on qualified health plans. So these are plans offered in the exchange, Vermont Health Connect. And it would be entitled Limitations on Hospital Reimbursements. So it starts out with that same definition of Medicare adjusted base rate. And then it specifies that for items provided and services delivered at a critical access hospital, the Medicare adjusted base rate. Medicare adjusted base rate shall be determined under the applicable Medicare prospective payment system using the Medicare payment methodology that would apply if the hospital were not designated as a critical access hospital. So that's sort of the definition there.
So that just explain that eliminates critical access hospitals?
No, it just says, it
Okay.
just says don't use the critical access hospital methodology for determining the adjusted Medicare adjusted base rate. Use the applicable Medicare prospective payment system. And if you want to know what all those distinctions mean, I'm going to defer to submission.
So that was because, going on memory, what you explained, the critical care gets, critical access hospitals get more or higher reimbursement rate from Medicare. Is that right?
They get a cost plus reimbursement rate, so all of their allowable expenses are covered plus one.
So that's why you're making that change?
Yes. Can I defer to the board why should the language carve out critical access hospitals and say don't use critical access hospital payment methodology,
Right.
prospective payment?
So we would like to move towards a standard definition that can be applied across all hospitals. Doesn't actually change how they're paid. It's just saying we're going to use this methodology to establish the same reference point. So it's just a clean way to all be talking about the same number.
So, and if I can just clarify, so it may be that a critical access hospital or a particular hospital based on its needs gets a higher percentage of that
Yes.
Medicare adjusted base rate because of its needs, but it's saying in the methodology, use one
Use
Medicare
one
methodology
definition.
Yes.
for figuring out reference-based pricing, and then the pricing itself may vary based on the hospital's needs.
But it gives the board regulatory.
It's
It
simplified.
yes, it's setting a single standard, sort of a single vocabulary that everybody's using for that.
Yeah.
What the Medicare rate is. So you can compare apples to apples. Okay, so that was just the definitions. Now we're saying a registered carrier, which is what a health insurer that offers a qualified health plan is called. So in this case, it's really Blue Cross and MVP for their qualified health plan market.
I'm gonna bring up something to add in here as we go in a little bit. So why don't we go through it and I'll come back to.
So a registered carrier shall not reimburse or agree to reimburse a hospital more than 250% of the Medicare adjusted base rate for any item provided or service delivered in Vermont to an individual enrolled in a qualified health benefit plan. So this would have a particular 250% reference-based price caps on hospital reimbursements for people on qualified health plans. In the event that a registered carrier reimburses a hospital for an item or service on a capitated or other non-fee-for-service basis, the carrier shall ensure that its reimbursement method is adjusted to account for the reimbursement limit set forth here. So they have to still adjust their reimbursement so that it's not more than 250% of the Medicare adjusted base rate.
So I'll just go up to B1 and I've had conversations both with VSEA and V5, which would be the NEA folks, and they would like to be included in B1. So not just QHPs as it is here, but also include our VSEA folks and V5 folks. And so I'm just bringing that up as an addition here. It will help going forward.
Sure, there are many takes on that, many views on that. All right, the reimbursement limit in subsection B will apply until, so that 250% cap will apply until the applicability date specified in the Green Mountain Care Board rule establishing the reference-based pricing methodology for all items provided and services delivered in Vermont hospitals. So again, this is sort of an interim measure that will be revisited or modified when the board actually has reference-based pricing in effect across all services. And it prohibits, so D is prohibiting a hospital or hospital provider that is reimbursed in accordance with that cap from balance billing, from charging or collecting from the patient any additional amounts other than the cost sharing amounts authorized by the terms of their health benefit plan. And then it uses some language similar to what was in Act 55 last year around the outpatient prescription drug cap. And it says the purpose of this section is to reduce healthcare costs, and a hospital shall not increase the amounts the hospital charges other commercial plans or private payers for prescription drugs, procedures, tests, imaging, or other healthcare goods or services in an effort to offset revenue reduced as a result of this section. So there should not be cost shifting to account for the 250% cap. Then we get into hospital outsourcing. So this would strike all of the language around hospital outsourcing. So the intent language, the purpose language, the limitations on outsourcing, the specific requirements around financial assistance policies and provider taxes, and instead require that for fiscal year 2027 hospital budgets, the Green Mountain Care Board shall direct hospitals to provide such information as the board may require regarding the clinical services that the hospital outsources to external entities. And on or before January 15th, the board, after consulting with hospitals and their contracted independent providers and assessing the impact of outsourcing on access to and quality and availability of care, would provide findings and recommendations to this committee and House committee regarding hospital outsourcing. And in addition, the board, in collaboration with the Agency of Human Services, would report on the extent to which hospital outsourcing affects provider tax revenue and recommend any necessary modifications to the provider tax provisions to appropriately reflect expenditures for patient care at Vermont hospitals. We get lots of views on, I'm sure, on that page. Excluding reference-based pricing from the scope of healthcare professional bargaining. So this is taking out the provisions that were of the bill that had eliminated the healthcare provider bargaining, the healthcare professional bargaining groups. So that's these sections themselves are struck. So the underlying law remains the same. The repeal is struck of the section of healthcare provider bargaining groups, and instead that section will be amended to carve out reference-based pricing. So notwithstanding any provisions of this section, to the contrary, The Green Mountain Care Board shall not be required to negotiate with a provider bargaining group or engage in a non-binding arbitration process in connection with the board's establishment of reference-based pricing in accordance with various provisions that direct the board to do reference-based pricing. No changes to the language around appeals of Green Mountain Care Board orders or hospital audits. Data infrastructure, this is the
So this is where, so we haven't finished a discussion on some of these things. Go ahead.
data infrastructure. This is the Green Mountain Care Board Health System Performance Tool. And they had requested some changes. So this would now say that requires still the board to develop and maintain a public interactive tool displaying information on health system performance. But instead of some of the specifics in the bill as introduced, this would say including information regarding quality, access, and affordability. And then instead of requiring the board to update the information at least quarterly, it would require the board to update it on a regular basis to the extent operationally feasible. Then this creates a new study committee. This is a new section that I don't think the committee has discussed. And this would create the Public Employee Health Benefit Authority Study Committee. Potential for a different name to be developed by this committee or
Keep thinking about a new name. I have one, but who knows?
it's a slightly different from the language I was provided, but for one thing, this creates a study committee, not a task force.
Yeah.
In my mind, a task force is sort of what you do to operationalize something that's already been decided upon versus a study committee. Or to, do deep dive. A study committee is really looking at an issue and making recommendations about whether an issue is worth pursuing, sort of my mental calculus on terminology. So this creates the Public Employee Health Benefit Authority Study Committee to evaluate opportunities to establish a state authority to develop and administer comprehensive and affordable health benefits for all public sector employees in Vermont. It would be composed of the following members who shall each be appointed by the entities that represent the state treasurer or designee, a member representing the Vermont State Employees Association, a member representing the Vermont NEA, member representing the American Federation of Teachers, a member representing the electrical workers, a member representing the American Federation of State, County, and Municipal Employees, a member representing the School Boards Association, a member representing the University of Towns, member representing the state college system, a member representing the University of Vermont, and a member representing the Department of Human Resources. The study committee would consider the topics set forth in this subsection and produce a report regarding the potential for establishing the Public Employee Health Benefit Authority to provide and administer health plans that would meet the health care and wellness needs of Vermont's municipal, state, public school, and public college and university employees and their dependents, including addressing all of the following: the manner in which health benefits are provided to public employees in other states, including Oregon and Washington, the similarities and differences in level and scope of coverage provided by current health plans offered to public employees, the similarities and differences in the current service or contractual agreements negotiated by public sector parties with commercial health insurers, third-party administrators, and independent clinical and analytical vendors, uniform design, coordination, and administration of medical and pharmaceutical health plans, care networks, wellness initiatives, and medical privacy protections, uniform standards and protocols for contract review and negotiations with hospital facilities, non-hospital healthcare providers, commercial health insurers, third-party administrators, independent clinical and analytical vendors, and pharmacy benefit managers. Streamlined auditable processes to confirm the integrity and accuracy of billing from and reimbursements to hospitals, non-hospital healthcare providers, and vendors. Opportunities to secure substantial and sustainable cost reductions for employees, employers, and taxpayers. Monitoring and management of fiduciary risk. Public Employee Health Benefit Authority governance structures, deliberative processes, and equality of decision-making by employer and organized labor representatives. Staff positions, member and patient advocacy, and problem resolution on behalf of employees and employers. Uniform standards and systems for collecting, analyzing, and securely transmitting data on clinical utilization, quality of care, and other essential metrics to support health benefit plan management and vendor needs. Almost done with this list. Opportunities to expand participant access to primary care, mental health, and community-based healthcare services. Redirect care from hospitals and their emergency departments to less costly settings, and improve chronic disease management and medication therapy adherence. An alignment of authority operations and health benefit plans with the transition to reference-based pricing, global hospital budgets, and regional care transformations directed by acts of the General Assembly, including various acts from 2024 and 2025. The study committee will provide recommendations regarding a detailed blueprint with timelines to design, build, and launch the Public Employee Health Benefit Authority, the need, if any, for independent consultants or advisory personnel for establishing the authority and going forward to support its mission on a regular or intermittent basis, and the projected costs of creating and annually funding the Public Employee Health Benefit Authority. By December 15th of this year, the study committee would submit a report detailing the information to the General Assembly, and I added in the governor. Since it deals with state government. Assistance, the study committee would have the administrative, technical, and legal assistance of the Office of the State Treasurer and may engage the services of one or more consultants or firms to assist with facilitating meetings and public hearings and preparing its report. Directs the State Treasurer or designee to call the first meeting of the study committee to occur by August 15th of this year. Designates the State Treasurer or designee as the chair. A majority of the membership constitutes a quorum, and the study committee would cease to exist on January 1st, 2027, after delivering its report. Requires the study committee to schedule public hearings, both remote and in person, to allow public sector employers and employees the opportunity to share their healthcare needs and concerns with the study committee before the issuance of the committee's report. Requires commercial health insurers, third-party administrators, VHI, and clinical and analytical vendors serving the public sector to provide full and timely access to the study committee with appropriate non-disclosure agreements in place as needed to their, access to their service contracts or agreements with relevant public sector entities and any data, including claims, actuarial, financial, and other data that the study committee requests. I put some placeholder language in here so you could decide if the members of the study committee would receive per diem compensation and reimbursement of expenses, and if so, how many meetings, and how much would be appropriated to the Office of the State Treasurer from the general fund for per diem and compensation, per diem and reimbursement if provided, and for the services of one or more consultants or firms. Finally, the act would still take effect on this issue.
Deep breath. Okay. So that last section is, unfortunately, weren't able to have testimony from what's going on in Oregon. And they do have a public employee authority where they've established a system for health benefits for public employees. And
Like you, I was looking at them a little bit yesterday and Monday and working on this language. And I do think they administer state employees and school employees separately. So there may be some combinations or some risk pooling that happens, but they do seem to have pretty different or somewhat different administration.
And I have talked with the VLCT, VHI, and VSEA regarding their interest in being part of this pool process and looking at a broader risk pool and developing a more attractive way of acquiring insurance and health benefits. That's a lot. So let's go back to the beginning of the bill. And first of all, I'll just say, I don't see a lot of people who might require per diem, but I could be wrong there. Didn't look like it.
Right, it's generally people who are not compensated by their employer for their
Yeah.
participation.
Didn't look like.
So those who are appointed by unions, for example, may not be being compensated by their employer for their participation.
Okay, so let's go to the beginning of the bill. And then walk through and we'll stop, make decisions. I know I can see there are people around the room who want to comment. We'll do that. And then we'll get to the bigger working group that's there.
Okay, so we start in reference-based pricing, and the first change here is the board suggestion to add provider contracts amended or renewed, as well as those entered into on or after October 1st.
So what I'm gonna ask of folks around the room is if you have a comment that you'd like to make, you don't have to comment that you like this. What would be helpful is if you have a comment that would improve the language from your perspective. So if you have that, just raise your hand. Yes,
Devin Green, Vermont Association of Hospitals and Health Systems. I do appreciate the collaborative process on this. Again, I think the Green Mountain Care Board should be doing the actual conversion. I don't understand why hospitals are required to do the conversion when we give the Green Mountain Care Board our prices.
and then the
Is that
board.
specific to C here, or is that later on?
I'm looking, we're just looking at the
C, correct.
C. You're talking about the collaboration between the board and representatives of Vermont hospitals.
Emily Brown, Green Mountain Care Board. So for this one, I think I'd just like to go back to the fact that the legislature asked us to start implementing reference-based pricing in FY 27. If we are going to be able to do that, that requires the hospitals, insurers, everyone who is part of the healthcare system to start looking at their prices as a percent of Medicare. So to me, they should already, hospitals, insurers, everyone should already be starting to transition their contracting and how they price things and how they look at their pricing as a percent of Medicare. If they don't do that and we then go ahead and implement a rule, or whether it's in our guidance, start referring to prices as a percent of Medicare, and the hospitals do not have data and information that shows them what their prices are as a percent of Medicare, I don't know how we as a system are going to move towards that. We don't have all of the hospitals' specific prices for every single service that they cover. We don't have that information. So I don't understand where this assumption is coming from, that the Green Mountain Care Board was at some point going to be feeding information out on what every single hospital charges and what the percent of Medicare is. We are happy, and I think we've done so here, provide an explanation of when we say as a percent of Medicare, what that means. But I think it's on the hospitals in the system to go back and look at their prices and figure out what that means as a percent of Medicare as described in this bill.
So just talking about the language in C,
Correct.
and then so you're suggesting that.
I disagree with it being a collaborative process. I think we are happy to issue guidance or provide further guidance, but I don't understand. We don't have the resources to work with every hospital and provide the technical assistance to convert their prices to Medicare. We don't. So if that was going to be the requirement or the expectation, we would need more further resources to do that.
So instead of collaborative process, the hospitals don't like it, you don't like it.
So to be clear, this is the items and services identified pursuant to a collaborative process. So the requirement is that for provider contracts, hospitals and health insurers use express or begin expressing rates as a percentage of Medicare for the items and services identified pursuant to a collaborative process between the board and representatives of Vermont hospitals.
So you just identify items and services.
I think that every service, the way that things are paid for are going to have to be described as a percent of Medicare. I don't know how you then identify a subset of that if we're trying to regulate prices across the system.
So is it better to think that it's initially a collaborative process. I'm thinking that this is like
There's no
going up
benefit
a ramp.
there. Yeah, there's no benefit, Elena Barabee,
Okay, go ahead.
to doing just a subset. I think if
Understood.
hospitals are going to have to do this, doing it for all services is really just do it once. And then we know where we stand. And I think we know where hospitals stand as a basis of Medicare is a really important baseline information to have as we move forward. So we know how things are changing.
Okay, and that does say earlier in the paragraph, each hospital and health insurer shall begin expressing. So there is an implication there that it's a process. Which is not gonna happen, but it begins October 1st. And it's going to affect 27. So, and then it's the rates for items and services identified in a collaborative process. So that's the collaborative process that is in question. I'm trying to get the wordsmith there.
Green from Buzz. We're this does feel like a matter of resources. Green Mountain Care Board says that they don't have the technical assistance to help us do these calculations. We also don't have the resources to do these calculations necessarily with what is happening. And so we would be interested in a collaborative process and beginning to look at this. We can work with this language, but we were also just trying to figure out the reasoning for the language.
Okay. Senator Morris.
Madam Chair, so the rates for items and services identified pursuant to a collaborative process between the board and representatives of the rural hospitals. That can be a tremendous amount of services, right? Or it could be smaller amount of services.
Mhm.
And would it be better off to set up some common services that every hospital provides, that's known, measurable, that's easy to do, and then continue to move that forward as far as services?
Can I say something there?
Yeah.
We don't want to be the regulators. That's something the board will do. And so, yeah, think about it. Once we start down that pathway,
Right.
yeah,
But the way, look, the way this is worded doesn't prevent the collaborative process to do that between the hospitals and the Green Mountain Care.
Yeah. I just don't know what services means. They're gonna figure out, I guess, what services means.
it's a collaboration. You see,
Yeah.
you know,
Well, I don't know if
never
it
been
is.
to a hospital.
You're saying it's I think I'm hearing it must be struck.
That we can't do this one. This is too complicated for us and it'll take
Yeah.
us too much time. Like, give us 4 months to come back with that one. Let's
Yeah.
do this one.
Yeah.
Honestly, when I hear from patients, after we talked about this, and I talked to some folks over the break about, I get my bill and it's got everything itemized perfectly based on all the stuff that's going on. So how come I'm hearing that the hospital can't sort that out for the regulator? So there, and then I hear, why can't the board, move faster on this? And I'm hearing all of it. So, okay. So committee around this table, how does this all sugar off for you? I'm fine with it. I think it makes sense. It puts some responsibility on both sides of the fence here. And people have to work together to get to.
Yeah, I get itemized things in my insurance and Medicare saying, this is what they charge, this is what we pay. Somebody the hospitals know what they're getting paid by Medicare patients, and that I assume is the Medicare Right. It would take some doing, and I can see where, given I'm sure there are a million billing codes or more, where it's gonna take some time to work it through. And maybe you start with the ones that we saw are the most egregious, which is labs and outpatient
Well,
things,
maybe, I mean, that,
maybe,
yeah.
but
Up and down, you can't regulate.
Right.
But I think with a collaborative process, the goal being that we're going to have all of it that way. And I don't know that we need to say by next year, but within X number.
They're beginning.
Yeah,
It's a beginning.
it's a beginning.
It's a beginning. It's a big process.
So do you think they're going to collaborate?
They have in the past. I,
Okay.
you know, I do. Depends on people's attitudes. We can't legislate behavior, but we can suggest it.
Play,
So I'm gonna.
I apologize, Emily Brown again. So regardless of whether this goes into statute or not, and there's a collaborative process. Going back to my comment, if the expectation that we are going to be doing reference-based pricing and enacting a rule that is probably going to be effective and require hospitals to be offering prices as a percent of Medicare, then it doesn't matter what services we identify, they are going to have to know what their services and what the prices are as a percent of Medicare. And if we don't require it here, which is your choice, they are still going to have to do it, because then if we can't say hospital X, you need to be priced at X percent of Medicare, and they don't have the data, and then they come back to us and say, we can't do that because we don't have the ability to do that, then that's a larger problem.
We get it.
Yeah, okay, thank you.
I mean, my only comment is if you don't do a collaborative process, and you put rates in place, it's gonna be one of these. And so
Yeah.
both sides have to work together in order to come up with things that they feel are workable.
Yeah, and I'm sure we'll hear about it. One last comment.
And agree, as part of the calculation piece is the definition of the Medicare base, which is different than what hospitals are receiving now in this legislation. So it would
Okay,
be
so
a different
that's the next-
conversation.
So
if the Medicare base was-
we'll look at that language. I know you said this was, Janet said this was different from what the hospitals had suggested. So we need to look at what the hospitals had suggested, and then we'll try to make our decision about that. Nothing is, so let's move on. I think we're gonna leave this the way it is now, and then we can move ahead.
Okay, the next piece is giving hospitals until October 2027 to apply for use and unique NPI for services delivered off campus. Any concern about that? Then there is the change. Or the language here saying, until the Agreement Care Board rule applies, on reference-based pricing, hospitals will implement commercial rate reductions ordered by the board under their hospital budget review authority by first reducing hospital commercial reimbursement rates that are more than 500% of the Medicare adjustment. Or if they don't have any of those, then targeting the highest reimbursement rates in the region for Medicare adjusted base rate, and having commercial or further increasing prohibiting any further increases to a commercial reimbursement rate that was more than 250% of the Medicare adjusted base rate as of July 1st, 2026. And going along with this is the definition of Medicare adjusted base rate. I just want to confirm with the board, was I supposed to add this critical access carve out there as well? Did I just drop that?
I think that makes sense.
Yeah.
Okay, so it's supposed to have the second piece that you saw in the next section that says if it's critical access, don't use the critical access specific methodology because we're trying to put everybody on the same methodology.
Okay,
So that was my mistake in.
so go through that again, Jen. That is
Just there should be a second part of this definition of Medicare adjusted base rate that mirrors the version in section 2 that says if it's a service at a critical access hospital, then still use the same consistent
got it. So
Medicare payment system and not the hospital's own specific critical access methodology when establishing what the Medicare adjusted base rate is. I'm not saying what the price has to be, but just
So 500, or you're trying to get that below that, and then if they try to increase by 250.
right. So targeting anything over,
Right.
first targeting anything over 500
Yeah.
or the highest ones and not be further increasing
What
anything that's over 250. That is what the language here says. This is a proposal from the board.
so this is where the hospital may work.
Sure, that was read from Boz. We actually really appreciate this proposal. We've been wanting to address our high prices for a while. We want to work on it. And this provides a good framework within the budget process to do that work. So we appreciate this proposal. We would even offer to come forward in the budget process with our proposals in that spirit of thinking about it and being transparent. As opposed to doing it after the fact of the budget in place. Where we are concerned is on the definition of the Medicare adjusted base rate and how that comes into play. Our understanding is that places like Oregon have used the full Medicare payment. And like I said, hospitals know what they get paid with their adjustments. So things that consider the fact that there's the wage price index or just policy decisions for those hospitals. We know we're getting paid there. And we think that those should carry forward.
Emily Brown, Green Mountain Board. I don't want to jump ahead, but I think there is some relevant language in section 2. So while we were going through this process with developing this language with Jen, I think that there was some overlap happening here. So the intent of the proposal in section 2, which was directly related to the QHP market, setting that at 250%. I think the board would prefer, so the goals here are to first apply so there is a budget process that will be happening concurrently with this adjustment. And I think it's the board's preference that the savings accrue to the QHP market. So in place of the language we have here, I think we prefer that the QHP market be set at 250%. We're assuming that in many instances that will allow the hospital to meet its budget guidance of -1%. In some instances, it's a little higher. And then if the hospital is not able to meet the budget guidance with applying the QHP market rate of 250%, then we would like them to target the savings at the higher services as outlined in section F, little I1, I think it is. And because I think that the idea is to have the savings accrue to the QHP plan, which right now, as many of you are aware, is in a very vulnerable state. But we also want, I think this section 2, which was essentially a freeze on prices over 250%. We are concerned that if you have that additive to the QHP market adjustment to 250, that will be too much money out of our
So
hospital system.
caution hospitals to the QHP from savings, basically.
Essentially focusing the hospital budget savings to the QHP market. And then if there is a hospital that for some reason with that market adjustment for the QHP it doesn't reach the budget guidance, then we would like them to focus the savings at the higher price services. But if, I think we don't agree that, with section 2, which, says a hospital shall not increase any commercial reimbursement exceeding 250%. That's essentially a price freeze. And I think, again, we're concerned that if you do that additive to the QHP changes, that will be a larger financial implication to the hospitals that wasn't part of our original analysis when we brought forward the QHP market changes. And I think we were viewing it as the QHP adjustments, and then if needed, targeting the higher prices in the rest of the market.
So you're suggesting taking out the not increase anything above 450%?
Correct. Yep.
And then is there a reference in here to QHP? Do we have, is there clarity?
No, I have to.
We have to fix that.
We would
I
have
know.
to fix it. Yeah, apologies to Jen. We didn't catch this. But it would essentially be in many ways combining the provision of section 2, which has the relevant QHP provision, and then having that be the primary function of the
Exactly.
hospital meeting.
Understood.
Good. Okay. Thank you.
That's helpful.
Yeah.
It might help the hospitals.
Um.
I'm always going there.
So reading from Buzz, we are concerned about the 250% for the QHP plans. We understand the goal of helping that market. So we do see that. I think what we're seeing now is other groups wanting to get into this 250% space already, which could have a negative impact to our hospitals. When we look at reference-based pricing in other states, Oregon does it for its employees. It's something like 30,000 people. The other,
We haven't got a lot of those.
right. But I'm just saying, the other states that do this for maybe 1% of their population, a very small percent of their population. And so I would want to be very cautious, because I think there's a scenario. I appreciate the Green Mountain Care Board saying 250% will get you to your budget. But I think there's a scenario where the 250% for a hospital that has a large amount of Medicaid and QHP plans could really hurt their budget more than what's expected. So instead of going down by -1%, they're going down by -5%. And I would say that's more the vulnerable hospitals in the state.
Well, this is exactly why it's important to leave it up to the Green Mountain Care Board and not up to us. But I know the board, you want to comment back.
Yeah.
This is a good discussion.
Yeah. So I think I hear, right, the concern about hospitals being impacted in different ways depending on where their QHP population is. I think the reason why we chose this approach is because we regulate the rates in the QHP market, right? And there's a desire by the board over the past several years to keep those rates lower. There could be a scenario where we don't do anything to control the underlying costs of the QHP costs, and then the board approves a very aggressive rate reduction for QHP plans, or doesn't offer the full QHP requested rate increase. We want to get away from the situation where we are relying on our insurers, our domestic insurers specifically, to, in that situation, subsidize a decision to decrease rates. We also want to stabilize the QHP market so that we don't have this year-over-year issue with QHP prices growing, and really not a mechanism to effectively control that outside of then cutting a hospital's budget.
Understood. And so we get it. And
Yeah.
I know that there are 2,000 less people signing up for
Exactly.
QHP,
Yep.
and that's one of the big concerns that we
Exactly.
all have.
Yeah.
So, okay, so we're taking out, let's remind us where we are, taking out.
So we're taking out one thing, we're moving another.
We're taking out
Um,
little Little I.
Yes, so you would, so basically be taking, we're gonna move, I think, all of this elsewhere.
Right.
Okay, so because we'll be combining what is now F1 here, and the targeting the highest reimbursement rates, as as sort of an order of operations after application of the 250% reimbursement limit for QHPs, and then saying if there is still room for reductions to meet the hospital's budget, then apply commercial reimbursement rate reductions to the over 500 or highest. Taking out 2 here, the overall cap, and then we don't need a separate definition, because it'll all be in one section, and I think about where that goes.
Okay. Yes, yeah.
Devin Green from Buzz. I am concerned that there is actually nothing in here about making QHPs more affordable by doing this.
Making what more?
QHP, the qualified health plan.
Right, there has to be that link. I agree. You need some link there. It can't just
I
be,
agree.
we're doing this.
I agree that there should be an expectation of savings, Emily Brown, that those savings are passed through to
To the
the
consumer.
consumers through
Well,
premium reductions, correct?
That has been my biggest recent,
Yep.
my biggest recent comment.
Yeah.
When I met with some folks in Bennington a week or so ago, and the one thing I said was, if we do all of this work and it doesn't translate to keeping premiums low for people and money out of their pockets, it doesn't do any good at all. So we can't just send it off to insurers or others, period.
And Emily Brown again, I just also want an opportunity to address the comment that was made about VHI and VSEA
We're
and.
not there yet.
Okay, I'm sorry.
Apologies. I just add.
We're not there yet.
Okay.
Are you gonna talk about the same thing?
I was gonna talk about the link between the
Oh,
premiums.
let's talk about the link.
Yeah,
And for the record,
for the record, Michael Barber, General
Yeah.
Counsel, for the Mountain Fair Board, to understand the impact of a cap such as this on those premiums. The insurers and the hospitals, they'd have to know what the Medicare adjusted, what their rates are as a percentage of the Medicare adjusted base rate. And so we could factor that in, right? So that it has to be quantified.
I understood. Okay. All right.
Devin Green from Buzz, just for the record, we are opposed to the 250%. I know that I made the suggestion about the affordability, piece,
Okay.
but I just want to make sure that we're clear on that.
Understood. Understood. I think there are some conditions in here that might ameliorate your concerns, but, and sometimes they have to lean one way or the other, and if good faith and trust don't hold forth, then we come back to this.
The goal of this is that some control of cost, but it is not to put any hospital under. So I assume that if the numbers come in and 250% is going to bankrupt a hospital, that adjustments will be made. And I mean, that to me is just the underlying,
It is.
I mean, we're spread.
So you may want to include some, sort of a relief valve in here, allowing the board to modify the 250% if it's, if it is.
That's a good idea.
Is that,
Yeah, and I
because
would like
otherwise
to
it
think
is 250%.
Yeah.
You can't change that.
I think we need the data, but then I also, I think there was similar language in Act 55 that they could apply through the budget process. for
Yeah.
some type of adjustment.
Yes, there was.
Yeah.
So I would recommend
Yep.
that it not necessarily be that you're adjusting I think it could get messy if you were adjusting the 250. I think it could be part of the budget adjustment process.
I think that's really a helpful suggestion. Yeah, I mean, we don't want a hospital to go under at all. We need everyone that we've got. That's what started this whole.
Okay, great. So what I think I'm doing then is I am, as we talked about, combining the 250% for QHP as the first go-to for commercial rate reduction, commercial rates. And then if there's any room left for commercial rate reductions within the hospital's budget, they would apply to the services over 500% of the Medicare rate or the otherwise highest price services. We will add potential budget adjustment language allowing the board to modify a budget like in Act 55 with the hospital is in dire straits because of the application of that provision, and also specify that the board needs to ensure that these reimbursement limits are reflected in QHP premiums.
Yes. And are we at QHP yet? Because we're gonna have to get there. Where are we now?
Yes, so now that we've sort of combined them, we're in the QHP section.
So, and I would like to add VHI and VSEA, and there are reasons for that. We hear consistently about how our taxes are going up because of healthcare costs. And this is just one more step to take that will help people in our communities. So, we'll talk about getting the money back to the lowering premiums. This is one way to do it. I'm suggesting that.
Can I,
This one more.
is Emily Brown, a clarifying question? Are you talking about applying the 250 to the VSEA and the VHI plans, or incorporating VHI and VSEA into the QHP?
Susan putting, I don't think we can just categorically put them into QHP?
I'm just asking for,
Not it.
yeah. I'm just-
Ultimately, might lead that direction.
Okay.
You know, it might lead to a larger group, but I'm thinking this is really to keep them in the 250.
Okay. All right. And
So this is applied, so we would be adding them to section 2 to apply the 250%. Cap.
They'd be in the
And they wouldn't be in the pool. It's just about how much the hospitals get paid for the services that they deliver.
And there's still the off ramp during the budget process.
Not for, sorry.
so Emily Brown, Green Care Board. So we do not regulate VHI and VSEA rates. VHI rates are regulated by the Department of Financial Regulation. VSEA rates are not regulated. It's my understanding by anyone. So the Greenmount Care Board would not have any authority to essentially effectuate those cost savings to the plan members. I also would like to highlight that I think currently the small group market, which this 250% cap would apply to, is open to small groups. So if there are municipalities, I'm not sure at the ability right now of schools to have the option to buy QHP plans, but it would enable small employers who would like to have access to that preferential pricing to enter into the QHP market if they would like to. I am also concerned that adding the additive of the VSEA and the VHI to the 250% budgetary for hospital impact would be way beyond what we had originally estimated for the impact of doing this in the QHP market. also want to point out that the board is working on the system-wide reference-based pricing, which would then in the future impact the VSCA and VHI plans. So the point of focusing this on the QHP market this time is because that market is in a very vulnerable state with all the federal changes that are happening. And so because the board regulates those premiums, it made sense to us to start there. To try to shore up that market and strengthen our regulatory market that we have.
Declining.
Correct.
So-
So I'll end my comments there. Thank you.
So what I'm hearing you say is, oh, it's in the future to do this anyway.
Correct.
Why can't we reference that? And so what I'm thinking about is, do we have to come back here every time the board needs to take another step? This is bothersome to me in the biggest way.
I 100% agree with you. And I think what we've heard loud and clear from this committee since the beginning of the session is that we need to move faster. And we are moving as fast as we can. We have our RFP.
We get that.
Responsive. And my point being is that we are not planning on asking for every single step. We are going to implement a rule that is a system-wide approach. I think what we see right now is a market that is at a high risk of increasing premiums and, really just kind of a market of last resort, which we do not want from a policy perspective. So again, if we have the ability to create an immediate fix that applies to a market, which again, we regulate the rates on, I think it makes sense to do that as expediently as possible while still focusing on our larger healthcare.
Understood.
change.
Okay, I
Thank
get
you.
it.
Yeah.
But what I'm suggesting.
Yeah.
Is that we reference the role of DFR in working with regulation of other entities. And include some future steps for the Green Mountain Care Board that would be involved with that. And that would include VSEA and VHI. Because I think if that's something that's in your future, then why can't we just reference it now and point in that direction? Because I think it's huge. I think that's like 60,000 lives that could be brought in to this. Understanding that it will have an effect all over the place. But if it's a next step, why not reference it as a next step? So I'll yield on putting it in immediately into the QHB. But having it next step might be something we could do. And I see that on your here. Go ahead.
Yes, Colin Robinson, Vermont NEA. Appreciate the conversation and support the suggestion as originally presented around including the VHI pool, which covers about 35,000 lives, and understanding that the SBA is supportive of that. I do just because I know folks' time and knowledge changes quickly as calendars march on, but the Senate added language to the budget bill in 24 that actually had the Green Mountain Care Board do an analysis and study of taxpayer savings that would be realized by moving to a reference-based pricing system for the VHI pool and the state employee pool, including specifically the number of 250% of Medicare. And I don't need to tell you all that conversations about the costs of education, and specifically how healthcare costs, as Senator Cummings mentioned, have impacted that. And the last full year of analysis presented in the GMCB report released in December 2024 showed at 250% of Medicare, just in the VHI pool, would be $27 million in savings to property taxpayers. I also just want to clarify, my understanding is Oregon, which does have RVP for public sector workers, that covers 300,000 workers in the state of Oregon. So a very sizable portion of folks. So definitely understand and appreciate the cadence that the board and this committee is working on. I think as it specifically comes to the intersection on healthcare affordability in the QHP market, as well as tax affordability, property tax affordability specifically, it seems like there's a real opportunity with this work of the committee and the work of the board in this transition moment to actually take an affirmative step and apply the 250 to the VI pool specifically in this moment and potentially stay.
Okay, so I'm gonna suggest that we hold the final decision. I've given two options. One is immediate inclusion and the other is referencing it for going forward in 27, 28 future. So I want to leave that, but we're going to have to get to another bill in a few minutes, but I wanted to go through the rest of this bill.
I mean, the frustration has been ever since we started talking about this. If we go too fast, I think we need to remember that the majority of our hospitals seem to be in various shades of pink or red. Our most prosperous hospitals, right, just on the line of adequate. That if we go too quickly, we might find people having to drive 100 miles to deliver a baby. That's the balance. And even though there's an urgency to cut drivers and VHI is negotiated contracts. They could try and negotiate with hospitals. I think the goal is to go there, but the goal is also not to put hospitals under or to cause undesirable cuts in services so that people need to drive long distances, which goes against our environmental goals to receive health care. And in some days, it's absolutely impossible to do safely in this state. So
we see if it wasn't, not easy.
Can I just correct the record on something? Devin Green from Baz, real quick. You're right. I was wrong on the Oregon piece. I was thinking Montana. It was only 30,000.
Yep.
Oregon would actually exempt all our hospitals with the way they do it, because they keep critical access hospitals out. They keep household community hospitals with Medicare comprising over 40% and hospitals with 50 or fewer beds. So
they have a lot more hospitals.
right.
Colin, thank you for that clarification. I will say in previous conversations around this, the recognition of critical access care hospitals is something that obviously we understand as well. And, if there's language related to that would need to be appropriate for this. Understood.
So that's a third option. It is, put it in immediately and then reference critical access hospitals. Okay. Let's do this. We're going to come back to this bill. My agenda. We've made a lot of important decisions. We're coming back to it to me. Say let's see.
Yes, we're
Looking at Wednesday.
the voltage.
Thursday, we could come back to it. So let's do some thinking about this. Right now, I do want to include some language on this. I know it's, that report that we got from the Green Mountain Care Board was very compelling. And it's one of the things that has driven this whole process. So there's 60,000 people sitting out there with savings that will accrue to people who are can't pay their premiums. And many of them have stopped. So I think we should have something in there on that. So please do some thinking on this committee and we'll come back and maybe we'll talk with Jen about having some options on the table for us. And I know everybody else will be by this. That's what we do. Okay. Are there any other major decisions that we?
Oh, lots.
We're at the page 5. Yeah. Okay. But the other ones don't seem as.
We have to decide what you want to do on outsourcing. And
Yeah, I think the language is fine that we have put in the, reporting.
well, I don't think the board thinks it's fine. I'm not just being more than, but,
Let's hear from the board and then we'll go to 197.
Emily Brown, Green Board. I think we appreciate gathering more information. I think our position still stands that we do believe that outsourced services should be captured within our hospital budget process and subject to all the same regulatory levers as other services that hospitals offer. We don't want to outlaw or ban outsourcing. We just want it to be integrated and hold hospitals accountable for that cost that is going to insurance premiums and consumers.
Okay. Understood. I don't think that's a bad idea, looking over at them. To have outsourced services included in the budgeting process.
Devin Green from Baz. No, that is back to the original proposal. And that regulation of outsourced services, we are worried about access and losing those outsourced services. We would like to gather the data on this and make informed decisions before we risk losing things like emergency department services.
Okay, so we'll think about this one.
okay, then you have
Some of
the
these things don't get resolved without breaking the jam.
The audit requirements.
Oh, yes, I do. All right, we'll come back. We're gonna come back to three things, then we'll come back to the audit report, the outsource stuff, and the QHP inclusion,
how about the study committee?
the study committee and the study committee. Yeah. Okay, we're gonna come back to.
Yeah.
Okay, let's, okay, so let's move on to 197. And do we have, we do.
The 197, I have language that's still a little bit in flux, but that I've been working on with AHS and the Vermont Medical Society. I don't think it's posted yet, but if you want it to be posted, it can be. Plus, it has it. I just forwarded.
Let's look at it and we can decide whether to put it up permanently and we can put it up temporarily. Just to.
So do you want her to post it for now?
And then we'll depost it. Because it's a work in progress.
Well, I mean, largely there's one piece of it that I think is still open.
Okay.
You got
So
the changes.
so I'm not,
Yeah, you got the changes. You make changes.
yes. I think it's just getting posted now.
Okay.
It's only for sections 1 through 3, so the rest of it. If you have not.
We were going through making some good progress, as I recall, on this one. And so we probably should look at what you have 1 through 3. And then go back and go through the bill and look at our decision points.
Yes, and some of them I don't know, based on what's in 1 through 3, if they'll still. Okay. All right, so we are looking at some potential revised language for sections 1 through 3 of S-197. S-197, by way of reminder, is an act relating to establishing a primary care payment reform program. So the first is some of this I've done in markup, but some of it is just replacing. So I've marked up section 1 to modify based on the AHS-VMS work. So it now say is the intent of the General Assembly to invest in primary care, and then instead of by establishing streamlined primary care payment system, you would say by, through streamlined primary care payments that build on the blueprint for health and will promote, and it still says the rest, promote the public good by increasing access to primary care in order to improve the health of Vermonters and reduce healthcare system costs. Section 2 would replace, section 2 of the sections 2 and 3 of the bill as introduced. So if you remember, the bill as introduced set up a primary care payment reform program that would kind of aggregate money from payers and provide a per number per month capitated payment to primary care practices.
We can do something with Medicare on that.
When they participate. So they have historically participated in the Blueprint for Health.
Okay, so that's where you're
Part of our
going. There.
right,
Okay,
as part of
all right,
our
all right.
arrangement with them, when they have participated.
Gotcha.
In, if we participate in the head model, I think they're back in
Yeah.
at that point.
Thank
Yes, but it has to be with their
Their blessing.
approval.
pretty
Yes, and their active participation. So this would amend the blueprint statute, blueprint chapter. We may need a few more updates as we go along, but starts out with some definitions, clarifying that health insurance plan is a major medical insurance plan. Basically the same language that's but updated. Health insurer, I've largely pulled in the definition from section 18 VSA 9402. So it's a broad definition. Any person that offers, issues, renews, or administers a health insurance plan or other health benefit plan in this state, and includes, to the extent permitted under federal law, third-party administrators administering a health benefit plan offering coverage in this state or providing administrative services only for a health benefit plan offering coverage in this state. So that includes the self-funded to the extent that we are permitted under federal law. Section 7, then it jumps to existing section 706 of Title 18 and adding into health insurer participation payments to practices. So under existing law, health insurance plans must be consistent with the blueprint and health insurers must participate as a condition of doing business in this state. This would add language saying, in order to facilitate development of the sustainable payment models necessary for the blueprint's success, health insurers must submit to the Agency of Human Services at least quarterly or more frequently upon the agency's request, all information the director of the blueprint deems necessary to perform a comprehensive fiscal analysis of the total cost of care in the state and to implement one or more payment models addressing healthcare capacity, volume, quality, and clinical outcomes. Change some language a little bit. So under existing law, it says the blueprint payment reform methodology shall include per person per payment months to medical home practices. This would expand that to say participating practices, including medical homes and primary care providers. And then under existing law and keeping it here says by each health insurer and Medicaid for their attributed patients and for contributions to the shared costs of, and again, expanding from just community health teams to operating blueprint initiatives. Under existing law, a person per payment, PMPM payments to practices must be based on the official National Committee for Quality Assurance and TQA's physician practice connections, physician patient-centered home score, although some of this terminology may be getting updated, I believe, to Jessa, but I think there's just some terminology updates reflecting changes at NCQA, or another quality standard. This would add, or another quality standard identified by the blueprint director in consultation with the blueprint's payment implementation work group to the extent practicable. So based on NCQA score or another standard identified by the director to the extent practicable, provided in addition to, and just updating some language to be a little bit more clear, practices typical fee for service, not their normal fee for service or other payments. And then this would add, and from health insurers in amounts at least equal to Medicaid beginning in 2027. And don't worry about the structure language. This is what I'm continuing to work with the stakeholders on. So currently, it's my understanding Medicaid payments are more than insurers, so looking to equalize those. Then just some reflection that the blueprint is no longer in the Department of Vermont Health Access, but is within the Agency of Human Services at the central office. So changing references to the Commissioner of DVED to the Secretary of Human Services. Taking out the specific requirement that enhanced payments to healthcare professional practices are those that operate as medical home, instead saying including medical homes and primary care practices. This is striking a reference to naturopathic physicians, not because they aren't included in being eligible to receive these payments of their primary care practices, but because there's broader language elsewhere that just says they're in as primary care practices. So we don't need to pull them out here. That has been expressed offline to the representatives of the naturopathic physicians, so they are not worried. Then in formulating recommendations, this new language would say the director shall strive to achieve or maintain parity across payers and payment methodologies. Then it keeps existing blueprint language, and then adds under appeals, adds references to the Secretary of Human Services instead of the Commissioner. Then this would add a new section in the blueprint chapter on primary care spending targets, directing the Agency of Human Services to establish a target for the amount of per person per month spending on Vermont residents that should be for primary care services, and develop a transitional schedule that increases that target over time. So this will replace language in the bill on primary care spending targets. It allows targets to be adjusted to reflect payer-specific differences such as age and health status, and it requires the increased spending directly to the per person per month payments in that new updated blueprint section. Then there would be a report. So new section 3, honor before January 1st of 2027, the director of the blueprint, in consultation with the Blueprint Executive Committee and the Vermont Steering Committee for Comprehensive Primary Health Care, established in last year's Act 68. Shall report to this committee and the House Healthcare Committee regarding changes to the payment amounts or payment reform methodologies, or both, that are necessary to transition the blueprint's PMPM payments to primary care practices to include payment for the routine primary care needs of attributed patients who are covered by participating health plans. So kind of looking at how to continue to build on the blueprint for all primary care, routine primary care payments. The report would define which services should be considered routine primary care, address any differences in methodology for different practice types, make recommendations on risk adjustment and attribution methodologies, describe the ways in which the methodology will balance capacity, volume, quality, and outcomes, include mechanisms for ensuring that health plans make accurate and appropriate payments to primary care practices in a timely manner, make recommendations on participation or quality measurement requirements for both, provide an analysis of including cost sharing amounts for individuals covered by participating health plans in the methodology, including the extent to which such inclusion would be permissible for a high deductible health plan without losing its eligibility to be paired with a health savings account, provide an analysis of ways to incorporate a primary care spending allocation target into the methodology, and provide an operational plan and description of any additional legislation needed to implement the methodology not later than January 1st, 2028. Be a new section, which I called Tier 3A, just because we were striking sections 1 through 3 of the bill as introduced, that would require also by January 1st, 2027, the Agency of Human Services, in consultation with the Vermont Care Board, report to the same committees the baseline per person per month spending on primary care services for Vermont overall, and by each health insurer, third party administrator administering a health plan or providing administrative services only for a health plan, Medicaid and Medicare. It would require the agency to use the definition of primary care providers and services from the AHEAD model, or a definition used by the New England States Consortium Systems Organization, NESC. So Section 3B be a separate report due by January 1st, 2028, so a year later, from the Agency of Human Services to the same legislative committees, with the per person per month primary care spending targets developed pursuant to that new section 18 VSA 710 added by section 2 of this act, as well as the proposed transitional schedule for increasing that target over time, any recommendations for payment, specific adjustments to the targets, and any additional legislation needed to implement and enforce those spending targets and that section. So that is the language proposed to replace sections 1 through 3 of the bill as introduced.
Okay.
And I will refer to the stakeholders to explain to you their rationale. It's just getting their ideas on it.
So I know that Dr. Saroyan is up on the screen and Joseph Barnard is here. You each want to make a comment on the first three sections.
I'm happy to in whichever order you desire.
Go ahead, Dr. Saroyan. Welcome.
Thank you. I've completely lost my voice.
Okay, well, if our ears are open. Would you rather that Joseph Barnard went first, or how do you want? Okay. Go ahead.
From the side is fine, or
Oh,
Do you want
is
to?
that okay?
yeah, you can move up here if you want.
Happy wherever you would like.
It's short.
Okay.
This has been a collaborative process.
This has been a collaborative process. Thank you. Yes, Joseph Barnard with the Vermont Medical Society. We've really appreciated AHS's openness to work with us and talk this through and come forward with a proposal that we hope not only really starts to move the needle for supporting primary care practices, but is also accomplishable and implementable, which is important. So really it's a transition. You know, we always, in bringing forth the bill as introduced, always envisioned that it could really work with the blueprint, but this just makes it really explicit that this is building, rather than creating something new or some other pathway of paying primary care. This is really building off of and strengthening the existing per member per month payments that already go to the blueprint. They already have a lot of that infrastructure and that payment model in existence. I'll just highlight some of the sort of bigger changes or how it work differently, or what this accomplishes. So a couple things that are really important to our primary care practices and members. It would first, we hope, allow a opportunity to bring in all payers, since all patients in Vermont are eligible to receive Blueprint services. It's a payer agnostic program. So patients of large employers, third-party administrators are already receiving those services. So this attempts to say all insurers participate and fund the program equally. So that's important, and that could increase payments to practices without putting additional burden on our QHP and regulated plans in Vermont, which I think is important to all of us as a state.
Totally.
So right. Yeah. So it gets more payers in, and then it also tries to equalize how payers are contributing. So saying that all payers should contribute equally to Medicaid. And then the next step is, how do we over time increase that payment to not only cover right now, if that's an add-on payment. In addition to the practices bill their payers, they get the fee for service reimbursement for whatever services they're providing, plus they then get this per patient per month kind of add-on. So we're saying first, let's look at, can we increase that sort of add-on payment? But really then the ultimate goal with the report later on in these sections is, can we look at, can that PMPM actually become more comprehensive and start replacing fee for service payments? Can we actually include some of those routine primary care services within that, so that practices are getting more of a flexible chunk of payment to take care of their patients? So those are some of the components, and looking at in that analysis of, could we include other services? Could we address patient cost sharing for primary care services in that analysis? Could that be something that premium dollars sort of are adequate and go to that payment in an amount that then patients wouldn't have as much out-of-pocket cost for primary care services? And then it has the component still of establishing a goal for what our state is spending on primary care services. One thing you'll notice, this language takes a different approach, rather than a sort of a percent of total cost of care. that should go to primary care. It actually looks at establishing a per person per month spending amount on primary care. And the reason to look at it that way, we collectively did some further thinking, research about this. It's a way to make it a more comparable measure for different payers, because if you're looking at a percent of spending going to primary care, it actually depends on how much that payer's costs are overall. So as that payer's overall spending on care changes, that alone could change the percent of the proportion going to primary care. So instead, this is more of a flat per person per month amount that is not as dependent on that payer's overall cost of care. So that's why the transition and how that would be measured. And I think that really highlights the direction we went. I'm happy to answer other questions. And again, really appreciate the collaboration with AHS and Viva and the Blueprint team. I know this required a lot of work on their behalf, thinking about it as well. I think the one outstanding issue at the top of page 3, there is still some highlighted language. Well, there is highlighted language about equalizing the payments between health insurers and Medicaid. We would we are working to see if we can get to a common understanding or agreement with AHS about also looking at an annual assessment of the amount of those add-on PMPM payments going to practices to make sure it's keeping up with the cost of complying with Blueprint requirements, maintaining patient access to care, all of that. So we know we have to be careful about how that's worded in terms of state-directed payments and things like that. So we're working to see if we can finesse some language that would at least ask for an annual review of what that payment amount is.
That's good.
Thank you very much.
I have one. Primary care, trying to get my head around it. I used to go to my primary care physician. It wasn't at a hospital. It was separate. And then that facility got bought, I think, by a hospital. And so you've got, are there independents out there, or the majority of primary care institutions, or I don't know what you call them, institutions, but are they hosted, owned, controlled by hospitals?
So primary care in Vermont, there's still certainly strong, robust, independent primary care. There is hospital-based primary care, and can't forget our strong federally qualified health center system of primary care in Vermont. So really 3 kind of models. I should have, I don't off the top of my head have which percent, have the
It
numbers.
seems like it's trending more one way, though, to me. Maybe not.
It's actually interesting. I would say that was a trend. Some of the more recent transitions have actually been from hospital owned to independent or FQHC in the past 2-3 years. As primary care, for better or worse, loses money many places. The reimbursement rates don't always cover the cost of providing primary care, and it's become harder and harder for hospitals to maintain that service. So, there have been a couple instances recently of both going to independent and going to QAC. But there was a big trend for not just primary care practices and general specialties as well in the 90s, 2000s of for sure.
I think UVM, and I would go to Burlington. It just seemed like UVM was buying up a lot of
Almost,
privates.
And they're still independent. Yeah. Okay, so I'd like to turn to the folks on the screen, and then we'll bring Jen back up. So you want to stay while they're talking? It's up.
Stay. Okay. I'll stay for.
Okay, so who do we have up on the screen, Mara?
Hi, I'm Mara Kraus Donahue. I am the Assistant Director for the Blueprint for Health, and I'm speaking on behalf of John today, or Chan today, as he has no voice.
That's a really good thing. Want to make it worse. Go ahead.
So I'll just go ahead with a general statement that we're extremely appreciative of all of the feedback from VMS and the other stakeholders, very appreciative of the willingness of the committee to work to modernize and build upon the Blueprint's foundation. I think that, we've been working hard to coalesce around some of this language, and I think that's been very successful. I would say there are still, as Jessa already mentioned, I think there is still some language that our team needs to review within AHS in terms of the annual updates and the state directed payments. So I would just flag that as an area under review for us currently.
Perfect, thank you. That's helpful. And so the flagging is good. The timing is tomorrow. That's just, you know, we're on such a short time frame right now.
And this was voluntary and then it becomes mandatory, right? As I recall somewhere in here.
The proposal in front of you does not transition anything to mandatory participation at this time.
And the bill is introduced.
In the underlying bill.
Oh,
That's fine.
thank you.
I will yield.
And one question here is, how is it determined what patient goes to what primary care physician? Is it the physician who says, is it the insurance? And then if we're, how is that part dealt with?
Yeah, so currently it is completely the patient's choice. Where they and would continue to be. The patient could choose whichever, I mean, obviously, you know, it may be hard to get into the practice they want to go to. But there's nothing that would change currently or in the future where the patient goes for their primary care services. The tricky piece then, or the next step is then the term is attributed. To which practice does that patient kind of count for which practice gets the payments linked to that?
That's what I was.
So there is, and I will defer to Mara, but typically, you know, whatever kind of value-based program it is, whether it's through an insurer, or the old ones through the ACO or through the blueprint, there are definitions of how you link this patient to this practice for the funding. And, you know, usually it's where have they gotten an appointment, visit in the past 12 months or something like that. So Mara could probably give for the blueprint purposes, how they currently attribute to a practice.
I'll go ahead and just jump in with that to the best of my knowledge. The blueprint has a 2-year look back, and during that time we look at claims. And there's a set of codes that are kind of generally agreed upon, but we do update them every year, of primary care codes. And then those would be filed based, you know, by a patient-centered medical home, by a blueprint provider. And the provider that has the majority of that individual's primary care claims over that 2-year look back period is the provider to whom the individual is attributed for our purposes and for payment purposes. So that is done based on claims, based on actual experience with a 2-year look back, and using sort of a generally agreed upon methodology. So there is, we generally don't have issues with that, but there could be, as you can imagine, a situation where a provider may say, oh, I saw this person 18 months ago, they're one of my patients, but actually then they started receiving more care from a different provider. And so we look, and if the majority of their care is given by a provider, that's the provider to whom they're attributed.
Thank you. I think we're going to move right along because we need to look at the rest of the bill. I am going to ask Mara and John this question. I asked yesterday in appropriations when AHS was in. I know that the 1115 waiver is coming up for review and this going on this next year. And I asked for information about how much money we'd have to put in the budget to increase reimbursement rates for primary care across the board by 1%, by 2%, by 5%, just to getting a picture of that. That would come from DEVA. I don't know who does that, maybe Ashley Berliner or someone else, but I'm asking for that data. I've asked for it 3 times now, and I'm hoping that the 3rd time will be the time that I hit the ball into the field and not strike out. Oh, there we go. Thank you. All right, so Jen, we're not going to go through the rest of the bill. This is my day. Huh? This It's okay. We're
I
gonna
have an 8 o'clock.
and FYI, before we do that committee, I'm thinking we will not start at 8:30 tomorrow. There've been some changes in the cannabis bill, and I'm not sure we need to look at it right away. So I'm going to say that we'll cancel that part of the agenda at 8:30. On the cannabis bill, and then we should probably know better than I do. We're gonna hold off on that.
That one's hard.
And we'll start at 9 o'clock, and I know my team will be happy to have that daylight savings. I know, daylight savings. I thought you were there already. That's what they said before you came in. I'm working on it. We gotta get rid of it. Unbelievable. It's just rushed. Okay. Okay, so we go back to the original bill.
Yeah, back to the original bill.
Yeah, yes, sure, yeah. Feel free to go.
We start on section 4 again, so.
Yes, exactly. Section 4 is on page 9. This is the, upcoming agreement care board updates some reports and updated version of the, what page is it on? 9.
No.
Of the Vermont Clinician Landscape and Site Neutral Reimbursement Reports.
Got it.
I'm not sure. I don't think I've gotten any direction on anything different here.
That's it. I mean, it's kind of a general question. We're reporting back to the committees of jurisdiction. Does it make sense anywhere in here to put health reform oversight committee or no? Because they're all coming in like in January, so I'm.
Right, so if they're coming in when the legislature's in session, I don't know that it does. I think even the members who are not on the
Yeah, so.
the committees of jurisdiction, but are on the Health and Oversight Committee are probably
Right,
busy
okay.
with their subject matter committees.
Okay.
Section 5 is a report on transitioning care to community settings. This is the Agency of Human Services. Report on transitioning care to community settings.
Yeah, that's.
And the agency, as my note says, AHS says they should, or maybe you said AHS should incorporate into the healthcare strategic plan as appropriate.
Uh-huh.
And I don't know if that's instead of this section or in addition or add in addition to this section.
Well, we'll put it in.
Okay. Section 6, I'm not sure the extent to which it is needed. This is language directing the Green Mountain Care Board in collaboration with the DQHC, Health Information Exchange Steering Committee, and Office of Healthcare Advocate, to look at existing regulatory structures for access to information from VCures and VUDS, the Vermont Uniform Hospital Discharge Data System, and recommend ways to improve access to the information for quality improvement purposes while preserving appropriate protections for patient privacy. There's also a piece about the board in consultation with VQHC recommending any changes needed to the VQHC billback statute that I think we have heard is not necessary.
I don't know what that means.
What? That's how they're funded.
I know, but
Yeah.
so you're changing it?
I think this, I don't know if there was miscommunication or misunderstanding or something, but I think it's the Department of Health that has the contract with VQHC, but I think, the Green Mountain Care Board handles the actual, bill back because the health department doesn't have bill back ability.
We build back regulated entities, right?
You do, but I think I need something from Jean and Nolan about
Okay.
who actually does what. But I'm not sure. I wish Nolan was still here. I think he's been in communications, and I'm not sure that this language is needed.
I'm thinking that it
the
probably
billback
isn't
piece.
needed after having conversations with folks.
Okay.
They're only the only question asked is one of the things that we've heard loud and clear is the need for quality measurements for primary care and blueprint as we go forward. So
Right, which I think was included in the language.
it's included in the language in sections one.
I don't know if there's still a live issue around access to VCures and VUD's data for quality improvement purposes, so board folks.
So I think we have a process where researchers and other state agencies can get access.
Yeah, this is specific for blueprint over which you
No,
know.
this is specific to BPQ.
Oh, no, this is the language that's here is.
Yes.
My concern is having data for blueprint outcomes. The auditor's report was pretty critical about not having that evaluation done. So my concern is that we have some language that directs our quality assurance folks for doing, and our blueprint folks for doing some outcomes, data collection and analysis, so that we can change that auditor's report. That's, I mean, so really making sure that we do get the clinical data that we need. I also understand, in talking with my primary care friends, that there is a huge administrative burden placed on primary care docs that really intervenes with their ability to work with patients. So we don't want whatever we have here to complicate that problem. So I'm looking to see.
Jessica Varner with the Medical Society. I do think there's language in the new sections, proposed sections on page 2 around ensure providing more information to AHS at least quarterly.
Yeah.
The director of the blueprint to perform both the fiscal analysis and addressing capacity, volume, and quality clinical outcomes.
Okay.
So that was new language suggested by that, but I think more directly gets at the blueprint access to data than sort of
Then they can do the analysis that.
I believe so, and not to speak for the blueprint to whether that's all of the data they need or are seeking, but I will just say that, and I don't know if they're still on, but they did, this was language that they suggested to add to.
Mara is on. Mara, do you want to comment? And John.
Yes. So, John, did you want to? You're on mute. Yeah.
I agree with Jessa.
Okay, John agrees with Jessa.
Okay, this is good. Thank you. That's not great. And I think that what we could do is take out that BPQH section that's there.
The whole section,
So it's
the whole
coming out.
section?
The
Okay.
beach.
Well, we could have recommendations about any changes to practice that would.
I don't know if anybody is
Is
actively
anybody
requesting
enthusiastic
that.
about that?
No, with
Okay.
Emily Brown, Green Mountain Board, I think we don't understand,
Okay,
don't really think this is necessary
not
unless there
your-
is some outlying issue that we're not aware of, but we're not aware of
They're
any.
asking the board to do a lot of things and maybe this
no,
one
this
comes
is
off.
just
their
fine.
plate.
I'm happy to have a strike for section
Great.
6.
All right.
Okay.
So then we get to section 7 and having the treasurer's office and have a collaboration with AHS or consultation with AHS collaborate with other northeastern states to explore the potential for a regional universal primary care program. And report back.
Okay, so then the other thing that we heard about yesterday, from Bob Bordone and, was, having some analysis of how to get more groups included in, moving forward with primary care. So it would be it would cost money to do that. We'd have to send an RFP out. We have to do an analysis of the pay for universal primary care. So it's really looking at how do we pay for it? How do we make it cost effective? How do we draw in more small groups and large groups, period. So the question is that,
How do the treasurers involved in this?
he does a lot of work with other delinquent states. And he's worked hard on prescription drugs, so we asked him if we do it, rather than send it out to AHS, Human Care Board, everybody's like swamped.
Go AHS, just
Yeah.
curious.
Yeah. Yes,
I
ma'am.
could just comment on the stakeholder engagement piece. I want to make sure the committee has not forgotten that you created a comprehensive committee or a committee for comprehensive primary care
Yeah.
last year that is charged with gathering a lot of stakeholder input and discussing the future of paying for primary care. They had a meeting on primary care payment reform last night. And we did reference that the blueprint needs to consult with them in designing the next steps of any expansion of the PMPM program. So just a little hesitation about fragmentation with another primary care sort of stakeholder process when I think we have a pretty robust committee going. I'm sure you could hear from that. You actually heard from Fane Holman, who's their chair, testimony when you first started taking up 197, and they're working on priorities, their priorities for sort of the future of primary care in Vermont. So I'm wondering if there's a way to really just work
Okay,
with that.
this is helpful, and yeah, no, and obviously Faye Holman has been very helpful to us in this process.
Do you want me to put up the language around that steering committee? Is that what you?
Yeah,
look at?
do that. And we might, here's the thing, there are, right now, this is Vermont Business Roundtable. And there are other small business groups, that are very interested in being a part of this discussion. And they're concerned about, being shut out because of cost. And they're very concerned about the cost increases they're seeing. So trying to, that's what the sort of working group idea, that's where that working group idea comes from. If we can better integrate with what's already happening, I'm totally for that. And I see that Elizabeth has her hand up. Go ahead.
Elizabeth Hogan, Agency of Human Services. We agree with BMS regarding not creating redundancies and to use our existing resources in order to guide this one.
So use existing resources. Uh-oh.
There's also
I do too.
Last,
Okay.
last section.
I was also going to say there's also the executive, the blueprint executive
to call
committee,
you right
which is
back.
pretty broad and includes payers and other stakeholders. So, and they are also tasked with being involved in this program.
The other piece I just wanted to flag in the bill, it's in aspect as 187 itself, is there's also section 8 would remove the sunset on the educational assistance program scholarships for primary care students at the UVM College of Medicine. And I think there's language in the, I don't remember if it's in the budget, but I believe it is in the budget that would do the same thing and specify there's money remaining. So it doesn't necessarily require new money to be added, although I'm sure people in that area would appreciate it, but there is existing money that because of this sunset would not be able to be spent in time. And so I think there's language similar, that the same removal of the sunset plus, actually, I don't think we had to put anything else in because of existing carry forward language. So this would do the same thing. You may want to put it in both places if you are prioritizing it, but this would remove the 2027 sunset on this education scholarship incentive program for primary care for students medical students going into primary care who commit to a service obligation in a more rural part of the state.
I'm fine with that. Again,
I just wanted to remind folks that was the
that'll be an automatic send down the road.
yes, although I mean it's in the budget anyway, but it doesn't require any money. The money is there. Money is already in the account. It's already been appropriated.
Before I call on anyone else, I have two things I want to talk about, including in this bill. And one is the extension of the prior authorization for primary care. Is this going,
And you, no, nothing's happening.
it's not ending? I thought it was ending this year. Was it next year?
I don't think there's a sunset on that.
Okay, all right, good. I don't want that one.
Exemption for primary care, I'm not aware
Thank
if
you.
you have an extension, I mean, have a sunset.
Okay.
There was some
Second.
language in a House bill that would further limit the scope, and that language has been.
Oh,
struck.
good.
So-
Okay, that's what I was worried about. So we don't have to worry about that one. Then the other one is that when an insurance company cancels its coverage for a specific prescription drug, that patients are notified by at least 30 to 60 days, because it can't be categorical that your drug is going off. So that's one I think is really important. I'm hearing about that from people on GLP-1, for example.
Emily Brown, I believe there is existing, putting on my insurance hat, there is existing legislation that at least
Like statute.
correct, that I believe was passed maybe a few years ago that required notification
Oh, change in formulary?
change in formulary.
Yes.
So that and DFR would probably be able to better answer that question.
Yeah, so we may, I just need to pull up the statute, but we may already have existing law on.
Oh, you did that. Yeah.
Yes, I think we did. I
When we did that.
think we did. Yeah, I just can't remember the citation.
I don't remember the notice provision, and I'm hearing from people that they didn't
Well,
know.
There might be some self-insured or unregulated plans that
Hmm.
are not subject to
Good
that
point.
statute. That's always
Excellent point.
that's always
Yeah.
the issue. I did have,
Yes, ma'am.
I'm sorry, I did have one comment before we leave the S-197 on section 4. I think we support doing that work. I have been informed that the last time we did that, we had a full-time staff position for that. So I just wanted to highlight the resource issue. That's
piece of it?
section 4.
Both parts or the,
Particularly the first one was a series of focus groups and a lot of stakeholder engagement that required in-depth. It's not just like aggregating data, it was one of that, so.
And wondering too, the just earlier points, is there a way to integrate that into existing, working groups or, open to that suggestion as well. I don't know if there's resources, other places that we could pull from.
okay. So as far as formulary changes, there is a requirement under existing law that on a periodic basis, but not less than once per calendar year, each health insurer must notify all individuals covered under its health insurance plans of any changes in pharmaceutical coverage and provide access to the preferred drug list. So that, I don't know if that was it, or if it was maybe just the PBM.
I think it might be in the
stuff.
PBM language.
Anyway, let's think about that.
Okay.
Last comment is,
I just want to add, as a caveat to my earlier testimony that, while AHS does not want to create redundancies, AHS still does have concerns about section 7, of the setting,
section 7 is.
the setting.
Oh, that.
Regional universal primary. care.
Right, yeah.
Okay. All right, so we are gonna go off live. It's been a very lively day.